When single tooth dentistry is not enough, you need to learn full mouth reconstruction. However, before you learn full mouth reconstruction, you need to know this important 6 differences between single tooth dentistry and full mouth reconstruction. In this video, I'm going to cover these 6 differences, and the last one is something which no one can teach you. So watch out for the last tip. Whenever I ask someone what is the main difference between single tooth dentistry and full mouth reconstruction, everyone without a doubt says occlusion. And yes, that's the difference number 1. Occlusion is really important because if you think about full mouth reconstruction, it is nothing but collection of single tooth dentistry in a single patient. So if you can prepare, let's say, a single crown or do a single build-up, you can do 28 build-ups. However, the main difference between doing 28 build-ups in 28 patients versus 28 build-up in one patient is how the teeth meet together. And if you know how they should meet together without breaking them apart, then that's the knowledge of occlusion. So yes, occlusion is really important and point number 1, but that's not it. Point number 2 is your knowledge of communication between patient and technician. You need to really understand how to communicate with patient. And I always tell my mentees that, whenever you're assessing patient, make sure these 3 things apply. A, you can get on with the patient really well. Like if you don't like patient or patient doesn't like you, then you should not be doing that treatment, even if it's a simple treatment or you know that you in confidence that you can do full mouth reconstruction, but do not treat that patient. It's not worth it. I know from many years of experience. Number 2 is patient's expectation is very high. Patient's nice patient, but they want really high expectation. I had a patient I saw yesterday where patient came to me for all-on-4 full arch implant consultation, and patient doesn't have much bone between mental foramina. And so I told her that, beyond mental foramina. So I told her that I can give you around 5 to 6 teeth on one side, so maybe 12 teeth all together. But patient wanted her full set, 7 to 7. And I said, this is not possible without doing major bone grafting, and patient wouldn't have it. So I told patient that this is not for me and I won't be able to treat her. So you need to be able to comfortably tell patient that you cannot treat her because of high expectation. Point number 3, when patient comes to you with the normal expectation, but you are not skilled enough to fulfill patient's expectation. In that case, you need to refer those patients. So in this point number 2, communication, patient communication, these 3 things you need to understand. Then it comes to technician communication. You need to understand how to communicate with your technician appropriately. Whether technician understands your language, technician may be an amazing technician, but that technician does not understand your language, then you need to make sure you find someone who can. In the beginning of the career, you really need technician on your side. I mean, when I started my career 20 years ago, I had some amazing technicians who were helping me, literally guiding me for smile design cases. So I used to just send upper and lower impression and bite registration, and technicians like, we need a stick bite, we need to know, have some photos. So technician really improved my dentistry. On the other side, if the technician is of the mindset that, I'll work with whatever dentist send me, then you may not get the work you deserve or your patient deserves. So sometimes you want a technician who really challenges you. Margin is not right. You could have put the margin a little bit subgingival. You could have reduced a little bit more, or I didn't need this much reduction, or can you send me more photos like patients' childhood photos or teenager photos so you can replicate the teeth the way they were when the patient was young. So again, point number 2 is communication between patient and technician, and this is something you really need to work towards. Point number 3 is risk assessment. You need to make sure that you are doing proper risk assessment for that one particular patient. Make sure that you have assessed patient's occlusion, you assess patient's TMJ, you have taken history, you are doing mock-ups in order to assess patients' capability of getting used to with new vertical dimension. So there are 7 steps of risk assessment I teach my students when it comes to doing full mouth reconstruction. However, these are the few steps you need to really understand, and that mainly relates to patient's compatibility with increased OVD, and also patient's appearance and how patient likes it, and patient's TMJ. So make sure that you've done proper risk assessment, because without doing risk assessment, if you start doing treatment planning or start doing treatment, and right at the end, the last thing you want to hear from patient is, I wish I would have known that it would be like this, I wouldn't have had the treatment done. So make sure that during your whole treatment process, you carry out risk assessment at every single stage, not just in the beginning, but in the middle and right at the end as well. So make sure you do risk assessment, and that is different than doing single tooth dentistry. When patient comes for single tooth dentistry, even if they have TMJ problem, most of the time you can get away with it. However, for full mouth reconstruction, when you're doing full mouth restorations, and if the TMJ problem gets worse, it's almost certainly because of your lack of planning. Make sure you do appropriate risk assessment. The difference number 4 is treatment planning by asking questions. Are you asking enough questions to your patients? I know I didn't. So make sure that you're consciously asking patient what do they want, what are their long-term goals, and many times when you ask patient, what are your 5 to 10 years goals, they would have no clue because nobody had asked them this question before. So make sure you ask patient the long-term goal and short-term goals. Is there any wedding coming up, or why do they want to have this smile design done? And what is their main purpose? What is their main why? Because if you miss that why, and let's say patient wanted nice, better aesthetics, however, now you're just purely concentrating on function and not the aesthetics, then patient might be disappointed. At the same time, if you concentrate on the aesthetics and the function's not ideal, then also patient might not be happy, where patient's primary goal would be function. So make sure you ask plenty of questions to your patients in order to understand their main reason as to why they want to do full mouth reconstruction. Difference number 5 is treatment planning and mentoring. What do I mean by that? When you do full mouth reconstruction, let's say when you're doing single tooth dentistry, you have a class 1 restoration coming up. You're not going to stay awake all night and plan that class 1 restoration. However, when you're doing your first full or second full mouth reconstruction, you need to spend considerable amount of time in doing treatment planning for that patient. So that's the main difference. However, when you're doing treatment planning for your first or second case, I would strongly recommend that you have mentor. And that's another difference, where you need to make sure that you have mentor when you're doing complex treatment like this, because you don't want to go through all the problems there is, whereas your mentor can help you, guide you through that journey without having too much bumps in the road. I tend to say, this is from Tony Robbins, I've heard that turn your decades into days by mentors. So your mentors can turn their decades of experience, can consolidate and give you within days. So make sure you have a mentor, and that's a big difference between doing single tooth dentistry and full mouth reconstruction. Is I truly believe that if you want to start doing full mouth reconstruction, doing properly, then you really need a mentor. And the last one is lateral thinking. Yes, it's a lateral thinking, and no one can teach you this. Not even I as a mentor can teach you this. This is something comes as an experience with the experience. When you get stuck, how are you going to get unstuck? And that's the thing you need to really learn and think about it all the time. Because lateral thinking is not natural for us, because we have been trained in a rigid way, we have been trained in such a way, and that works in the healthcare profession because we need to stick with the protocol, stick with the regime as strictly as possible, like cross-infection control, right? So when I'm doing my implant surgeries, I'm making sure that the cross-infection control is like operation theater style. We have been ingrained that in the mind, and that's why that reduces the flexibility. So make sure that you have that flexibility open, lateral thinking open, because you will get stuck when you're doing full mouth reconstruction one time or the other, and you need to really think laterally in order to get you out of that tricky situation, along with the mentor. So make sure that you follow these 6 points, and don't forget to click the link on the description to join our 8-part free email series to learn more about full mouth reconstruction.